We shall now go on to our next speaker, Dr. Jeewan Titiyal, and who's going to tell us an extreme scenario. And I'm sure he has an excellent set of videos to drive home when you would do this extreme step, losing flaps. On to you, Dr. Titiyal.
Yeah, thank you very much, Dr. Chitra, for a kind invitation. And most of the things have been covered very nicely by previous speakers. Very few things to highlight from my side. Yes, there can be a very extreme scenario for where we can lose the flap in the scenarios which can be intraoperative, where we discuss about the free cap, buttonhole in the flap, or sometimes flap laceration can happen. As far as buttonhole is concerned, it's very, very rare. In fact, now microkeratome use is so less, we hardly see these very difficult complications, which may be less than 0.4% now. The main risk factor I would understand is excessively a steep keratometry, which is going to be some sort of risk factor in these cases. As soon as you see a buttonhole, if you are sure that you have buttonholes, should not lift the flap in these scenarios. If you have some sort of irregular alignment of the buttonhole, then you might lift it, irrigate the interface, and put it back again for a proper alignment. These cases should be seen after 3 months, and make sure the refractive stabilization is there before you attend for a resurgery in these cases. Other extreme scenario where you can lose flap is a free cap, and most often we have been practicing when we used to do microkeratome surgeries, normally make two radial marks in the cornea so that you can align the flap appropriately in those cases. That would be helpful in our cases with a free cap also, and you can align the flap accurately. The important risk factor is mainly two. One is an inadequate suction happening these because of various anatomical factors. The second important may be a flat keratometry. So this just opposite to buttonhole happening in the flap in these cases. Once you have free flap, it's important to realize the size of optical zone and the free flap in these cases. If your flap is larger than the optical zone, there you can ablate the cornea. And if you have successfully retrieved the free cap, you can position onto the surface. If you have previously marked, you can align very, very nicely and wait for at least 3 to 5 minutes for it to get attached because of endothelial function. Very rarely you might need suturing or using a glue in these cases. More often it gets attached very nicely. Put a contact lens. Don't be in haste to remove contact lens in these patients. Maybe you can put it for at least 1 to 2 weeks. It's very important to examine these patients after 20 minutes to see that the cap is well attached in this case. So this is a scenario where if you have a mark here, you can always align these flaps. Sometimes there may be some difficulty, which is epithelial side or stromal side, but with a high magnification, you can see very clearly in these patients. I think the important scenario will come in the post-operative phase. There are two important segments. One is infectious and second is non-infectious category. So we all know infectious category is difficult. Sometimes we have to make a decision right on a time to decide what would be the actual time for sacrificing the flap. Previously, we used to maintain the flap, try to lift the flap, scrape it and treat. We all came to understand that interface infections are very difficult to manage. So it is to decide when actually we're going to do amputate the flap in these cases. So we had this patient, I think one of the early cases where the infectious keratitis happening in the interface. Slowly the flap melted out and ultimately we had to sacrifice the flap. In fact, the entire cornea to do a therapeutic graft in these patients. So this is another patient had undergone microkeratome assisted LASIK outside, came with a small area of infection which became larger. Then I had to do a deep antilaminar keratoplasty, which remained clear for 6 weeks. And again, the infection came back and ultimately we had to sacrifice the cornea to do therapeutic graft. So these two important cases make us realize that if you take a decision appropriate time to amputate the flap, you can treat the infection very nicely and save the eye in these cases. Other concern will be the traumatic flap dislocation, which happens in a LASIK cases. Even after many, many years, you can have a dislocation happening in these cases. This is one of our patients where had a flap because a dislocation is identified by the area of clear stroma visible from the flap edge, and it depends at the time of flap dislocation, less than 1 week or more than 1 week. You can manage these patients according to a time frame. Always, as we discussed, the documentation has to be proper. Assess the flap quality, do antisegmental OCT in these cases, and subsequently treat in these cases. I would like to show one case where we recently reported this case in a COVID time. The flap got dislocated because of a mask, the face mask hitting the flap edge in these cases. So this was a case, second day post-op, you can see entire flap got dislocated upwards. The identification factor is, in these cases, we saw the Dr. Sujata showing that flap folds, which are normally radiating from the hinge area, but in this traumatic dislocation or disruption, the folds are horizontally placed in most of the case. If you see here, this is the dislocation happening in these cases. This is a clear stroma, and this is the edge of a flap. So most of the time, it will get epithelialized within 24 hours also. So even you have a flap stria or dislocation happening, you have to remove the epithelium, and this horizontal fold is very difficult to manage sometimes. And it's very important, as Dr. Mahipal talked about, you need to dilate the eye. You can see better with the retroillumination. I have not lifted the flap. Without lifting the flap, I could took out these horizontal folds in these cases. It should take some time to make sure you do ironing in a proper manner. And this is the immediate post-op next day, nicely upposed flap and 6/6 vision subsequently. And people can read this case report in IGO. Other extreme situation will be where you have first flap dislocation happening. Patient did not report for more than a year. And at that time, you can see vision has gone down to 4/60, best corrected 6/36. And the refractive error is seems to be better. But if you see this patient had a total fibrous dislocated flap with a large epithelial ingrowth, and which would not make this flap viable even after you try to deposit this flap subsequently. So we did the topography. You can see totally irregular cornea with irregularly thickened fibrous flap in these cases. We did a IOCT guided removal of flap, and subsequently taking care of interface also, where is a large area of epithelial growth, which will also would require a treatment subsequently. So once we could identify the area, as I said, we removed the epithelium first. In these cases, it is important to remove epithelium from the area of clear bare stroma also, because it's a long standing, and there'll be a thick epithelium in those areas also. Once we could get a cleavage, you can, I had to amputate because this is almost half of a flap is visible. The entire other half of flap was not there. So we removed this flap. Along with this, the entire epithelial ingrowth also came out. And this, you can see that such a fibrous flap which cannot be retained. So we had to amputate this. And subsequently, this area was massaged out, all the epithelial cells. And I used, as we discussed regarding use of alcohol or mitomycin C. In fact, in this particular case, because it was a long-standing pathology, we used both mitomycin C and alcohol in this person, 20% alcohol. And subsequently, this patient, we followed up for a period of 1 month, 1 year. And you can see that surprisingly, vision came down to improve to 6/9 parts uncorrected and 6/6 corrected vision, and you can see corneal thickness looking quite all right, and bandage contact lens. This is day 1. And after 1 year also, if you see the topography, this was a pre-op topography, totally irregular, and this is the post-op topography, looks quite smooth. You can see cornea is now better, though there's a cylinder is there, and this patient will improve. So sometimes we do have to sacrifice these flaps also, despite being a chronically long time epithelialization happening in these cases. So another area which I like to highlight, this will be concern when you have extreme ectasia, when your bed thickness is less than 200 microns. We had described the technique of flap replacement surgery. Remove the elastic flap, complete the circle with your dissection, make a little pocket in the periphery, and put a full thickness graft after removing the endothelium, and put a multiple sutures. We described two cases way back in 2010 in Titiyal. And this is a good technique for extreme ectasia where you can just peel off the flap and replace with the graft. You have a very nice, smooth elastic flap in these cases. To summarize, I think extreme of losing flap is very rare situation in elastic surgery. Intraoperatively, free cap may be one situation where you lose the cap in between the keratome head and you don't have any other options. There you have to wait and let the cornea heal and then plan accordingly, maybe PRK in those cases. Sometimes keratitis may be a cause for losing the flap and requiring a therapeutic graft sometimes. But most importantly, the traumatic flap dislocation is the one where the very nicely done surgery can get totally disrupted with the flap getting totally organized, disorganized because of fibrosis. And normally all these cases will have a epithelial growth also associated, and you may have to sacrifice flap in those cases also. So if you examine these patients at the right time, if the patient reports back immediately after the trauma, we can salvage the flap in those cases. If they come late, then you may have to sacrifice the flap. Thank you for kind listening, and thank you again, Chitra, for giving this opportunity.
Wonderful talk, Dr. Titiyal, and amazing videos. We've also had just one experience. We had a range of experience, but how has the residual error evolved? As you said, in our case also the residual error was less. But has it ever been that you have needed a scleral contact lenses later for the irregular cornea, which remained at the end of it, or any such?
Put your video on, Chitra.
Yeah.
In this particular case, like we didn't try a sort of a PTK to smoothen the surface, which should have been we should have done. But luckily, after removing the flap, patient did very well. Now it is 1 year post flap sacrifice. He's doing quite all right, and he has some cylinder. And maybe we can plan a contact lens for that cylinder subsequently. You rightly pointed out, correct.
Thank you, Dr. Titiyal.